overdose typically are going to be sedated because of that opioid-like effect, and cholinesterase patients may have seizures. In terms of the physical exam, that's going to be most helpful for your cholinesterase inhibitors. You'll pick up that cholinergic toxidrome, but you can see some things that might help you. You might get some bronchospasm in the beta blocker patient. You can see some opioid-like effects in the clonidine patient, some meiosis potentially, maybe some hypoventilation. The glucose is mostly going to help you distinguish between beta blockers and calcium channel blockers. Right? Beta blockers cause hypoglycemia, calcium channel blockers can cause hyperglycemia, even in patients who don't have diabetes. And then potassium may be high for beta blockers, really no effect for the others except for cardioactive steroids. And remember, acute overdose of a cardioactive steroid causes high potassium. In chronic cardioactive steroid overdose, low potassium leads to more toxicity for any given level. So let's look at treatment. So for beta blockers, things that you probably want to think about: GI decontamination, right? A lot of these things are long-acting toprol XL, things like that. Fluid boluses for hypotension, right? Kind of knee-jerk, obvious response. Glucagon, right? Glucagon is another way to trigger the same second messenger system that I mentioned that epinephrine triggers. So if you block your beta receptor, you can increase your cyclic AMP indirectly by triggering it through glucagon. High-dose insulin is another way to treat beta blocker poisoning, and the mechanism of action is not really clear. It may be that the fact that the sick heart switches to glucose as its primary energy source. It's not really clear why it works, but empirically it seems to work. And typically we're talking about doses that are 10 to 20 times DKA dosing, so 1 to 2 units per kilo, pretty high dose. And you're going to need to give supplemental glucose along with that, typically a gram per kilo per hour to maintain euglycemia in a patient who has their insulin receptors saturated. So it can be challenging. It takes about half an hour to work. So if you're thinking about it, you want to think about it early if a patient has some severe poisoning with a beta blocker or a calcium channel blocker. But because you don't want to be starting it and waiting a half an hour to kick in if the patient is starting to decompensate. Amrinone is another way to indirectly raise your cyclic AMP by blocking phosphodiesterase. You can try intra-aortic balloon pump, maybe vasopressin, and things that aren't going to work, atropine, right? Atropine is probably not going to work. Transvenous pacing or transcutaneous pacing probably aren't going to work. I know Bob Hoffman likes to say you can't pace a meatloaf, right? This isn't somebody who has a break in their conduction system somewhere in the cardiac, one of the bundles of His or something. Every cell in the myocardium is poisoned. So it's, at a certain point, it's just not going to work, and it's not worthwhile to spend time on it. So I mentioned the fluid bolus. It makes sense as a first response to hypotension. It doesn't address the bradycardia. Glucagon, we use higher doses than we typically would for other indications, so typically 2 to 5 milligrams. You can repeat it in 10 minutes, so you can get up to a dose of 10 milligrams, and whatever works, you can give that much per hour as an infusion if you get a good response. Typically, I usually see a better response with the blood pressure than the heart rate, is my anecdotal experience with this when I've treated beta blocker poisonings with glucagon, but it definitely helps a lot. High-dose insulin, I already mentioned this, but remember it's 1 to 2 units per kilo per hour, so higher than our typical DKA dosing, and again, as I said, it takes 30 minutes to start working. The mechanism of action is unclear. All right, so let's look at calcium channel blocker poisoning and the treatment. Very similar list, right? There's one difference, is calcium. So calcium, we're going to want to give supplemental calcium to overcome that calcium channel blockade, kind of the similar idea of giving bicarb to a sodium channel blockade, right? And remember that calcium chloride has 3 times as much elemental calcium per amp as calcium gluconate, but you really should have a central line if you're giving calcium chloride, because if it extravasates, it's pretty devastating to the tissues around it. And you can always give just 3 times as many amps, right? You can give 3 amps of calcium gluconate, 3 grams of calcium gluconate instead of 1 gram, and it'll be equivalent. And in general, it's also more effective at improving the blood pressure than improving the heart rate. You can start an infusion if the bolus is effective. All right, so let's look at treatment of cardioactive steroid overdose. The definitive therapy for cardiac steroid overdose is DIG-specific FAB. So it's basically antibodies to the digoxin that have the FC portion cleaved off, the part that recognizes self as self. And there used to only be one Digibind. Now there's Digifab on the market, and that introduced a little bit of competition that initially brought the price down, but now the price is kind of going back up again. And I think it's like $600 or $700 a vial between these two. So it's like pretty expensive because a dose can be multiple vials. So who do we treat with DIG-specific FAB? Well, if it's an acute overdose, then EKG evidence of toxicity is an easy answer, right? So if you see dysrhythmias, obviously, and I think many people would even argue that a bunch of PVCs might be enough, that's an indication that you're likely to have dysrhythmias. A serum DIG level of over 10 to 15 nanograms per ml, that's just a high level. You're likely to get sick, so try to treat it early. Potassium over 5, based on the bismuth study that we talked about earlier, right? After an acute overdose, if your potassium is over 5, you have at least a 50% chance of death. And if it's over 5.5, you're almost certainly going to die without treatment. If you're just based on the dose of that was ingested, if you know that, it might be enough to treat. So an ingestion of more than 10 milligrams or 4 milligrams in a child is probably a reason to do it. And then empirically, for any EKG that looks like DIG toxicity, even if you don't have a history thereof. So this is a big thing that occurred with some of these herbal preparations that were sold as aphrodisiacs, and they were kind of DIG resin from a bufo toad, and it's supposed to be applied topically, but people were ingesting them. And so we were having young men coming in looking like DIG toxicity with no history of any medical problems and no history of being on DIG. And if you look carefully at the EKG and you see that DIG effect and a DIG consistent rhythm, then that can be enough to treat, even if you don't have the history that the person took it. So chronic overdose is more common and more controversial. There's no absolute indication based on what the level is, but really you're going to treat based on symptoms. In terms of dosing, if it's an acute overdose and you have a life-threatening dysrhythmia and you don't want to wait for a level, 10 vials is the dose for an acute overdose, 5 vials if it's chronic, or if it's chronic in a child, 2 vials. If you know the level, then the weight times the level over 100 is the number of vials. And that you always round that up. So if you get 2.1, you should get 3 vials. You can also use Digibind for non-digoxin cardioactive steroid toxicity, but it might not be the same dosing. You might need to give a higher dose because the binding isn't perfect one-for-one the way that it is for DIG. In terms of supportive therapy, you can do GI decontamination. Atropine can be effective for Brady dysrhythmias from DIG because they're cause bradycardia because of vagal tone. So this is different from beta blockers and calcium channel blockers. It actually will respond to atropine. If there's electrolyte abnormalities, you should correct them, and you can consider lidocaine or phenytoin if you don't have DIG-specific FAB. In terms of may be harmful, if you're a dog and you're DIG toxic and you get calcium, you can get something called stone heart. It's kind of tetanic contraction of the myocardium. It's never been reported in a person, but it's kind of considered bad form to give calcium to a DIG poison patient that you know is DIG poisoned. That said, there's plenty of people who were DIG poisoned that got calcium because somebody saw the hyperkalemia before it was recognized that they had DIG poisoning, and it's never occurred yet in a person. But still, if you know that it's DIG poisoning, you probably shouldn't give calcium. And then finally, transvenous pacing is a bad idea. It can trigger dysrhythmias in an irritable myocardium. And that's been shown in a case series by Taboulet in 1993. All right, I'm just going to spend a minute or two on toxicologic ischemia. And anything that causes vasoconstriction could potentially do this. Cocaine is by far the most common one that we're going to see. But remember, alpha agonists, ergots, triptans are all things that can do it. Any of you guys remember Seth Minogue? I know some of the attendings. He had an EpiPen and he stuck his finger. It's a common thing that happens actually, and had an ischemic finger from his EpiPen. That's not a cardiac effect, but anybody know what this is? This is ergot. It's a fungus that grows on rye, and that's where all of our medical ergots come from, as well as things like LSD, and they're all derived from this fungus. Sumatriptan is an example of a triptan. So in terms of cocaine ischemia, treatment of choice is benzodiazepines. You can also give aspirin because it is atherogenic, and some patients may have true lesions on their coronaries. Nitroglycerin as a coronary vasodilator. Phentolamine is another thing you can try if the other standard things don't work. There's actually a case report of ST elevation MI from cocaine reversing with phentolamine. One thing you don't want to do is beta blockers, right? Because then you have unopposed alpha and increased coronary vasoconstriction. People who have STEMIs should probably go to cath, even though a lot of the time it's going to be vasoconstriction. It might not be, and it's worth taking a look. And then the thing that's probably most important for us to know is thinking about disposition in patients with cocaine chest pain. And this is a study by Judd Hollander looking at patients with cocaine chest pain and taking out the patients that you would have admitted anyway, high-risk patients with known cardiovascular disease that are elderly, and those kind of patients this doesn't apply to. But the young patient with cocaine as their only risk factor, he validated a brief observation protocol with 2 troponins over a period of 9 to 12 hours. And if those were negative, they could be safely discharged. Initially in the study, he had everyone follow up for stress tests, and then they had such a low rate of positive stress that they kind of stopped doing that. One thing that is important is that all the patients were counseled about cocaine cessation. I'm just going to briefly mention, if you get a patient with an EpiPen to the finger, warm soaks or nitropaste can be effective. Nitropaste applied topically to the area. And you can also inject 0.5 milligram of phentolamine directly into the same spot that the EpiPen discharged. Yes, Scott?
Sorry, I don't know if I missed it, but what was the results of the study?
Yeah, there were no bad outcomes with that protocol. So that's something that you can safely do. If you have a patient who would have otherwise been low risk and 2 negative troponins, then you can discharge them with counseling about cocaine cessation. All right, I'm going to skip this because of time. Does anyone have any other questions? Yeah.
I had 2 questions. For the cocaine chest pain, it's always vasoconstriction, or assuming it's not a stent, like a true like a pot rupture. But is it always vasoconstriction that's causing chest pain, or is it other?
It's not always. I mean, so cocaine is atherogenic, and so some patients it is possible that they had actual plaques on their coronaries, and
right.
that it's an actual thrombus there, but.
But so when it's not plaque, or when it's that young person with no risk factor, presumed clean coronary arteries, if he's used cocaine, he's having chest pain because of vasoconstriction, and then...
I mean, I think that's what most people think. We don't know because most of those patients don't get cathed.
Right.
It's possible sometimes it's, anxiety or stress and things like that, but I think presumably that's the mechanism in most of these patients.
And then I personally never seen a troponin from these patients. Do troponins made sometimes?
It's possible. They usually don't, though, right? That's why we're able to discharge so many if we just get 2 of them.
Right.
Yeah, Guy?
So I know someone comes in, cocaine, adrenergic, agitated, acutely intoxicated. You don't want to give beta blockers because then we're going to have unopposed alpha constriction.
Yeah.
But let's say I did cocaine last night and I came with chest pain and I want my blood pressure. Like later, when you're not acutely adrenergic, there's no reason not to.
That's not really true because the reason is cocaine is gone from your system in a couple of hours, right? We don't actually, like if you do a urine drug screen, you're not testing for cocaine. Otherwise, they'd all be negative unless you got while somebody was acutely intoxicated. We test for a metabolite, a non-enzymatic metabolite called benzylecgonine. And benzylecgonine is also a vasoconstrictor. And so that's why people are at risk for cocaine ischemia after the point where they're acutely intoxicated. So you have the same basic rationale for why it's a bad idea, even after the person is acutely intoxicated if they use cocaine recently.
So would you use a 24-hour time period, or what time period would you
So I don't know that there's any really good data on that. The data on the increased vasoconstriction in the coronaries is with acute cocaine. It's basically a cath study on patients going for elective cath and infusing intracoronary cocaine and then intracoronary beta blocker esmolol and seeing increased vasoconstriction and then giving phentolamine and having it reversed. The data isn't there at the same level for the longer period. I think a day or two at least would be reasonable because that's how long your urine stays positive for cocaine. So probably if your urine is still positive, then you still have those metabolites around.
And by the mechanism you're describing, is there any reason not to give calcium channel blockers to that person?
There's no reason to not give calcium channel blockers, but at the same time, you have to consider, is there a reason to give them? So if you would have given it anyway for, if you were worried about their blood pressure or something, then you could do that. We used to think it was important to slow people's heart rate down when they were having an MI, and so people were much more inclined to want to give a beta blocker in the patients with chest pain. Now, that's not so much the case. But there was never any evidence that calcium channel blockers helped in that setting anyway. If you have a reason to give it, then probably it's safe.
A cocaine person who came
Yeah.
in with a tactic or, like with an SVT.
Yeah, so that would be reasonable. You could definitely use a calcium channel blocker safely in that patient. But you wouldn't use a beta blocker, for sure. Yes?
What about a dissection patient? Because crack and cocaine is associated with that as well.
Yeah, again, it's another patient that I would probably try to avoid. That's not the patient I would use a beta blocker on. If I felt compelled to use it, I'd use esmolol because you could turn it off. But I think I would rather give diltiazem or something to slow the heart rate and then a vasodilator. Yeah, in fact.
Two questions. One, what is the consent form for that study where they injected cocaine in the corners? And two, do you see this with meth too?
I think, see what, just chest pain? Or?
Yeah, the same vasoconstrictive chest pain.
So there's a lot less data on that. There's any adrenergic drug, all the amphetamines can cause ischemic effects. I have no doubt that you could have an MI with meth. It's not studied in the same way. Whether or not you can give a beta blocker either acutely or in the period afterward isn't as clear. It doesn't have that vasoactive metabolites that cocaine does, so it's probably less of a risk after the acute period of intoxication. But like I said, any adrenergic stimulus can potentially cause ischemia. But the data for some of the other effects, like the atherogenesis and things like that, aren't there.
Sorry guys, I'm going to move on.
Okay.
Talk to Dr. Wiener off the record.
Yeah, you guys can email me any questions and I can forward it to the list. And I'm also going to make the handout for the lecture available to you, including all the parts that I had to skip because of time. This lecture was originally created for an hour and a half slot, so I had to rush through some of it.